Hello, welcome to the High Risk Newborn and Birth Trauma lecture. I am going to break this lecture into two recorded lectures because this is a lot of information. This is basically our preemie newborn lecture, and then we're going to talk about some things that happen to our large babies during birth that can cause injuries just because of their large size. So you're going to use the same PowerPoint that is posted on Blackboard, and then I am going to stop recording at a certain point, and then I will start a second recording for the remainder of the lecture. The objectives. Okay, and so now we're going to start with some background information. This is some information just to help you understand the premature infant. We do classify our infants into categories based on their weight. And you do not need to you don't have to remember these numbers. I'm not going to test you on these numbers. This is just to help you understand how small of an infant we now can take care of. And when we talk about our preemie infants, we're talking about the neonate. And the neonate is the neonatal period of an infant's life is the first 27 days after birth. Okay, and that's why the intensive care for these newborns is called the neonatal intensive care unit. Now, when I first started nursing in the mid-80s, things were quite different for our premature and our very small babies. You can see here that we categorize babies as LBW is low birth weight. So this is a baby that weighs less than 5.5 pounds. We then have our next one, which is very low birth weight infants, and these infants weigh less than 3 pounds 5 ounces. And then we also have our extremely low birth weight infants, and these are our infants that weigh less than 2 pounds 3 ounces. Now, in the NICU, on the OB unit, we will always refer to their weight in grams, okay, because that is what is used to calculate any medications. But I did put them in pounds and ounces for you. So we're talking some pretty small infants. And you can see down here there are some examples. Here would be our low birth weight babies. They look like a smaller version of our term babies. As they get smaller, over here would be a very low birth weight baby. You can see that their physical characteristics are a little different. Their skin is different. They have much more complications because they're just not ready to do all of this on their own. And then your extremely low birth weight babies, which are very small and very fragile. Okay, to give you some statistics, and I'm not going to test you on the statistics, this is just to give you an idea of the survival rate of these babies. Okay, so a baby born at 22 weeks. Now I know we've discussed in class, your book says that 23, 24 weeks is considered viability, but this is still a very iffy situation, and it really depends on how big the infant is and if they are physically big enough for our equipment. Okay, so the survival rate at I'm going to go to 24 weeks. Survival rate at 24 weeks, they say, is 66%. Now, that doesn't mean that those babies are going to be healthy, because the survival rate without any severe complications is 44%. Okay, at 28 weeks, 98% of those babies will survive. Okay, and 94% of those babies will survive without any severe complications that we're going to talk about. At 30 weeks, the baby has a 100% chance of survival and a 100% chance of surviving without severe complications and going on to be a healthy newborn. Now, when I first started nursing, as I started before, in the mid-80s, if we had a baby come in at 28 weeks, we were very concerned for that baby, and we weren't very optimistic for their survival. And nowadays, a 28-weeker comes in, and we're really not very concerned at all, because our technology, our medications have just become much more advanced, and we know that we can take care of that 28-weeker without any problems. 24 weeks, 25 weeks, 26 weeks is still very iffy, okay? Even though the statistics for the 24-weeker was 66% survival, okay? So what you have to understand about the premature infant is that they are supposed to still be in utero, and mom is supposed to be doing everything for them. Mom is supposed to be oxygenating for them, providing nutrients for them, keeping them warm, taking away their waste, keeping things calm and quiet and dark. And now that baby is born and is expected to do all of those things on their own. Well, the main thing about our preemies is they do not multitask well, okay? They can't maintain nutrition, oxygenation, warmth, and do them all well. They really can only do one thing well at a time. And so they have trouble doing all of those at the same time. And so they need a lot of help, okay, so that they can grow and mature. So the first thing that we need to consider is their thermoregulation and how do they stay warm. Remember we talked about this with the term newborns, and it's not any different. They're more susceptible to heat loss, even more because their skin is much more thinner. And they basically, depending on how premature they are, they have no subcutaneous tissue or fat to help insulate them. And they're not able to increase their metabolic rate and shiver, just like the newborn, to produce heat. Okay, so they are very susceptible to cold and getting cold stress. Okay, just like we talked about with the term babies. And so some ways that we can keep them warm. When the premature baby is first born, if they're not very stable, they will go under a radiant warmer because this allows us easy access to do interventions when necessary. The problem with the radiant warmer is it's open and it allows drafts to go across the baby, which can make the baby cold. So if the baby still needs to be in a radiant warmer, another way to keep them warm is, yes, by using some form of a medical plastic bag, which kind of looks like a Ziploc bag. But what it does is it encloses or encompasses the baby's body and helps keep the heat towards the body, okay? Depending on the nursery, one nursery I worked at one time, we would take saran wrap and wrap it across the top of the radiant warmer bed, which did the same thing. It kept all the heat inside. Now remember, by doing that, this is a baby that is intubated on a ventilator, and so we're not cutting off any oxygenation or any oxygen supply by doing that because the baby's receiving that through the endotracheal tube. Once the baby becomes more stable and we don't need as immediate access to the baby, then the baby goes into an incubator or an isolette, which is completely enclosed. It's a little box that keeps the heat inside. Okay, and now we always, no matter which form of heat source we are using, we have to be aware of monitoring that baby's temperature and assessing for signs of hypothermia so that that baby does not go into cold stress. And so signs that your baby is becoming cold and going into hypothermia for the preemie would be they are going to start to have apneic episodes, which means that they stop breathing for 20 seconds or more. Their heart rate is going to decrease. They're going to have cyanosis, but remember the cyanosis is central. So you may see changes to their lips, their body, and their sugar is going to drop. Remember that correlation between their glucose and staying warm. They're going to use that glucose to try to warm up, which is why they become hypoglycemic. Okay? And so it's very important that we maintain that neutral thermal environment for them. Another thing that you would have seen if you had been in the NICU, hopefully, another way to keep them warm is called skin-to-skin contact, just like we do with our term newborns after delivery, where we put that baby to mom's chest. We can put our preemie babies on mom or dad's bare chest also. And it is a very effective way to keep that baby warm with their parents' body heat, okay? And so we can put any baby to their parents' bare chest as long as that baby is physiologically stable enough. So we have put babies that are intubated on the ventilator to their parents' chest because it just keeps them warm, and it also helps maintain oxygenation and things like that. And it also helps promote the bonding and attachment. All right, so what we're going to talk about now are some ways that we provide respiratory assistance. Depending on how many weeks gestation the premature baby is born, how much respiratory assistance they need will vary, okay? Hopefully, the closer to term that they will need less assistance. But that's not a steadfast rule, okay? So the first thing we're going to talk about is called hood therapy. Whoops. Hood therapy, okay? Or called more commonly an oxy-hood, all right? And you can see here, this is the oxy-hood apparatus. It's just this plastic kind of bubble type hood that the baby's head lays inside. You can see this connection here at the end. That is connected to the oxygen supply, and the oxygen comes in and just free flows inside this hood, and baby just breathes in the oxygen, okay? This used to be a very common way to give oxygen to babies who did not need high concentrations of oxygen. The problem with the head hood or the oxy hood or hood therapy, and one of the reasons why it's not as commonly used, is you can see here, you can see this opening around the infant's neck. They're not fitted to each individual infant size. So there's an opening here where room air can come in and mix with the oxygen. And so we may not be delivering the exact amount of oxygen that we think we are. So let's say we have this oxy hood set up to deliver 30% oxygen. Well, by the time room air mixes in there, we're probably not giving 30%, which is what the baby needs. So it's not always an effective form of oxygen therapy, okay? Some other things that you need to know about oxygen therapy with your babies, just like your adults, it should always be humidified, it should always be warmed, okay? Now, a little difference is in our adults, we always look for O2 levels or saturations above 95. Depending on the preemie, depending on how premature they are, you may see O2 saturations kept lower in, let's say, the low 90s. Because of their lungs, because we don't want to use too much oxygen, they may not react well to that high level of oxygen. We will adjust oxygen levels to keep their O2 sats at different levels depending on the infant's condition, okay? The other thing we have learned over the years is that we don't want to just deliver 100% oxygen to our babies. When we used to resuscitate babies, we would use 100% oxygen always. We have learned that oxygen itself as a therapy can create complications to the infant that can last a lifetime. It can affect their eyes, and it can affect their lungs and create chronic lung disease. So there is a whole program, an algorithm that has been created, the neonatal resuscitation program, which guides resuscitation and the use of oxygen levels with our preemies and keeping O2 levels at different levels based on the individual infant, okay? I know that was a lot for that slide. The other more common form of respiratory assistance that you'll probably see in the NICUs is nasal cannula. Many years ago, someone developed a infant preemie nasal cannula, and it has replaced the oxy hood in many of our hospitals, especially in the NICUs. Some smaller hospitals may still be using oxy hoods, but you can see that it fits the infant just like the adults. Prongs go in the nose. It is good for giving low flow oxygen. So if we have a baby that needs high concentrations of oxygen, this would not be appropriate. It allows the baby to be held. It allows the baby to feed with a bottle if they are stable enough, because they don't need to stay inside that head hood. So it allows the parents to hold their babies while they're on oxygen therapy, whereas the oxy hood, they cannot, because if they come out of that oxy hood, then they lose their oxygen supply. Okay, nasal cannula is also very commonly used for infants who need home oxygen therapy. All right, many of our preemies will be on nasal CPAP. You probably have not gone over CPAP yet, but CPAP is a way of providing oxygen with a continuous flow of pressure. Okay, so it basically keeps the airways open so that the O2 can get into the lungs, into the alveoli, and then cross over and go throughout that whole oxygenation process. Okay, so there's two ways. This is probably the most common form, is nasal CPAP. It's a little similar to, I'm sorry, I left all my show and tell at work in the office, but nasal CPAP is very similar to the nasal cannula, except the prongs are bigger. They have a wider diameter to allow for the pressure flow to go through them. So one of the problems with nasal CPAP is because you have these big prongs in their nose and it's delivering oxygen with a force of pressure, that some of that flow and that air can go into their stomachs, and it can cause distension of their stomachs, which can cause them to then maybe vomit and then aspirate. So one thing you have to do with a baby on nasal CPAP that should always be implemented, and you write this in red, flag it, highlight it, whatever you want to do. Any baby on nasal CPAP should also have an oral gastric tube, which is just like a nasogastric tube, except it goes through the mouth down into the stomach because of the prongs from the nasal CPAP. And it's just open to gravity or air. It's just to release any distension in the stomach so that we can avoid that distension and possible aspiration. Okay, so every baby on nasal CPAP should have an oral gastric tube to release stomach distension. Okay, and so this baby on nasal CPAP is still breathing on his or her own, but needs a higher concentration of oxygen and needs that flow to help get that oxygen into the lungs. Now, for our babies that are very unstable and need a lot of respiratory assistance, these babies would be intubated with an endotracheal tube that goes down into their lungs and is attached to a ventilator. So this baby not only needs help with oxygen supply, but also needs help with actual respirations, because the ventilator is going to provide breaths and help breathe for that baby. So this is a baby who is having a lot of difficulty breathing on their own outside of utero. Okay, now there are different kinds of ventilators that each baby can be on depending on their individual situation. I'm not going to go into all of those different ventilators because that would be something you would learn as a NICU nurse. Okay, now another respiratory assistance that has really changed respiratory status and decreased chronic lung disease in our preemies is artificial surfactant. So if you think back to your A&P, and if you learned about surfactant is a phospholipid, okay? I look at it this way. It reduces surface tension in the lungs, okay? So babies do not, or infants do not produce their own surfactant until about 34 weeks. So any baby born around 34 weeks or younger, may not have an adequate supply of surfactant. And so their lungs, when they breathe and the lungs expand, and then when they inhale and then exhale, is going to be stiff. And so that's what causes problems with oxygenation. So we can give artificial surfactant straight to the lungs through an endotracheal tube. Okay? Some NICUs have policies where any baby born at a certain week's gestation and under will receive surfactant after birth. Some NICUs will wait to see if the baby actually needs it. Okay, so until they go into respiratory distress. So what they do is there's the physician, respiratory therapist, and the nurse at the bedside when this is given. The baby is intubated with an endotracheal tube down to one lung. A dose is given. You bag the baby to disperse it into that lung. Then they will pull the endotracheal tube back and intubate into the other lung and give another dose. Because remember, there's two lungs, so we have to give a dose into each lung. And then they will bag to disperse it. If the baby is stable enough, they will remove the endotracheal tube and then put the baby on a different form of respiratory assistance. Maybe CPAP, probably CPAP at that point. If the baby is very premature and needs assistance with respirations, then the endotracheal tube will be left in place and they'll be put on the ventilator. Okay? Caffeine is another very common respiratory medication that is given. It's given either IV or PO in a syrup. Preemies are very prone to apnea, okay, which remember is when they stop breathing for 20 seconds or more. So caffeine is very commonly given to our preemies. It's a stimulant to the respiratory center of the brain that just reminds babies to breathe, okay? The other thing that you need to know or remember if you are working with a baby on oxygen therapy, no matter which form of oxygen therapy, we wean them very slowly and we wean them according to their numbers. So we watch their O2 saturation levels on the pulse ox. Sometimes they might even draw arterial blood gases to look very specifically at O2 levels and CO2 levels before weaning settings on the ventilator or the nasal CPAP or decreasing the concentration and flow rates on the nasal cannula and the oxygen. Okay, we never just say, oh, we think this baby is ready to go to room air and go from like 30% O2 to room air. Room air is 21%. Many times we will have preemies get down to like 23% O2 and you think, oh, we can turn this off and they'll be fine. But for some reason, some preemies get to that lower end of the concentration of oxygen and they just need that little bit. And so it takes them a while to wean off. So we always wean very slowly. Okay, nutritional care. Babies have a hard time multitasking, remember? So we need to help provide assistance in their nutrition. Now, we talked about the term baby having expected loss in weight. Your preemie is going to have a loss in weight during that first week of life also. They may actually lose a little more. They may lose up to 15% of their birth weight during that first week. Now, depending on the age of the premature infant will depend on how much nutritional support they need. You can see that between 32 and 36 weeks is where their suck-swallow coordination really develops. And so depending on whether their suck-swallow coordination is developed or not will depend on whether they're able to eat by a bottle and nipple or will they need gavage feedings with a nasogastric or an orogastric tube, or if they're so very premature, then they will be on parenteral fluids and get total parenteral nutrition and receive IV fluids that have electrolytes and also lipids. They will receive lipids in addition to that because the brain needs a fat to grow and develop. Okay, so Baby will be started very slowly, so if they are started on IV nutrition, then they will start probably gavage formula feedings at a very slow, small amount, and they won't decrease the IV nutrition until they know that the baby tolerates the formula or breast milk feedings. Okay, and we always go by how the infant is responding, whether to increase formula breastfeeding, breast milk feedings, and decrease the IV nutrition. Okay, babies that are on your preemies are typically always on I&O so that we can monitor what's going in, what's coming out. Another thing that we monitor our babies to tell if they're having any type of adverse effect to the feedings is we measure their abdominal girth. So typically, a couple times a day with their vital signs, we will just take a tape measure and go around their belly and actually measure it in centimeters and document it. We can't just go by our visualization of their abdomen. And if their abdomen is becoming distended, they're starting to spit with their feedings, then that means that maybe they're not tolerating their feedings or it's too much of an amount. So commonly, a common form of feeding assistance with our preemies is gavage feeding. As I said, it can be a nasogastric, where it goes through the nose down to the stomach, just like you learned in 210, or it can be an orogastric, which goes through the mouth and down to the stomach. This is the size tube that is typically used, either a 4 or a 6 French. They're very tiny. We can give feedings either continuously with a pump, because sometimes preemies don't tolerate dumping an amount of fluid into their stomach every so many hours. As they get older and get closer to term and going home, then we can put them on a bolus feeding, where we give them a certain amount every so many hours. So they might receive 20 mLs of formula every 3 hours. That would be a bolus feeding. A continuous feeding would be that they are receiving 2 mLs of formula every hour on a pump. Okay? Now, when your baby is on gavage feedings, whether it's nasogastric or orogastric, there are 3 things that you need to assess before each feeding. You need to assess their abdomen for distension. Okay, so you would measure their abdominal girth or circumference. Is it soft or is it tense, distended? Is the tube still in place? Babies move, so it's very easy for them to pull on their NG or OG tube. So you need to assess placement. Now, I know that you learned in 210 the correct way to assess placement is to aspirate gastric secretions and test it with a pH paper. If you are asked that question on a test or NCLEX, that is the proper way to assess placement. Now, I will tell you that if you work in the NICU, that in reality, how we test placement is we take a syringe and we push air through the tube, and while we push it, we listen to the stomach. And if the tube is in the stomach, we will hear a gurgle. Okay, I won't ask you a question about how to assess tube placement, but know that you need to assess it before each feeding. The other thing that has to be assessed before each feeding is residual. Is there any formula or breast milk left in the stomach from the previous feeding? Okay, now there can be a little bit of milk formula left from the feeding. Depending on how much feeding they're receiving, there are formulas where there's certain percentages. I'm not going to go over that because that is something you would learn and practice as a NICU nurse. What you need to know is that you need to assess for residual, because if there's too much formula left from the previous feeding, then that means that baby is not tolerating that feeding and digesting properly. And we just can't keep dumping formula into that stomach. So 3 things you have to assess before each nasogastric or orogastric feeding. assess the abdomen for distension, check that the tube is still in the stomach, and check to see how much formula is left over from the previous feeding. All right, one other thing I'm going to talk about before I stop this recording and start the next recording is non-nutritive sucking. What this means is that the baby sucks on the pacifier without being fed, okay? You would think that sucking on the pacifier might be more work for the baby, maybe stress the baby, but research has shown that sucking on the pacifier just at any time helps improve oxygenation because it keeps the baby calm. It helps promote weight gain because it keeps the baby calm. And it also just helps to develop that sucking reflex. So then when it's time for them to eat with a bottle and a nipple, they're able to do that. Okay, because remember that suck swallow doesn't develop till between 32 and 36 weeks. So it's very good for the babies to have them suck on a pacifier when it's not feeding time. Okay, so just during the day, anytime. All right, so I'm going to stop this here, and then I will start a second recording, and I will post this as 2 separate recorded lectures.